I'm Robert Heimer, professor of public health and pharmacology at the Yale School of Medicine. Today I will be talking about addiction, the principles behind addiction, and its treatment. So let's start with some definitions. We're going to define dependence, tolerance, withdrawal, and addiction so that we're clear on our terms. Dependence is very simply the physical or psychological need to continue taking drugs. Now, this is true for psychoactive drugs. It is true for non-psychoactive drugs. Examples of non-psychoactive drugs include insulin for diabetes, antihypertensive drugs for high blood pressure, statins to control cholesterol. All of these drugs we become physically dependent upon to restore a relatively normal physiological state. What's different about the psychoactive drugs is that many of them, all of them that are addictive, produce tolerance. That is, that over time, the need for the amount of drug to produce the same effect increases. This tends not to be true for non-psychoactive drugs that aren't affecting the brain, and we'll get into the mechanisms by which this happens in a bit. Withdrawal is the side effects that occur when you stop taking psychoactive drugs that you're dependent upon. Withdrawal is a set of short-term physical ailments that are associated with removal of the drug from the system. They occur for heroin, methamphetamine, cocaine, these drugs that produce dependence and addiction. But what separates addiction from these other words we've defined is that addiction is really a functional state that describes the continuation of drug self-administration despite negative consequences, whether those negative consequences are arrest or loss of jobs or estrangement from family and friends. A very good example of dependence is insulin, which can be used for treating two types of diabetes. The first type of diabetes is genetic. Insulin simply isn't available and it's necessary. Type 2 diabetes is more of a behavioral problem or behavioral disease that results in people who are obese, and do not get a lot of exercise. Not always people, not only those people, but in many people who fit that description, diabetes develops. And we treat those people, both the type 1 and the type 2 diabetes, two types of diabetes. We don't expect people to return to normal health when we remove the drug we're treating them with. They need to be on those drugs for the rest of their lives to have a normal, healthy life. In some ways, type 2 diabetes is much like addiction. It's brought on by a behavioral problem or a set of behaviors, but not everybody who behaves that way develops the problem, and that's true with the use of psychotropic drugs as well. Not everyone who uses them becomes dependent, becomes addicted, and has a problem that requires medical care. But what's different about the psychoactive drugs is that they affect the brain, and they affect other ways in which people behave. And one of the reasons they affect the way people behave is that these drugs, when they're removed from the system, there are immediate feelings of withdrawal. That is to say, the person experiences discomfort, sweating, vomiting, nausea, dryness of the mouth, dryness of the eyes, a whole series of very unpleasant symptoms and feelings that can be eliminated if the person takes the drug again. So there's a tendency, as a result of this, to take the drug again. But there is also a longer-term result of removing the drug. Even when the drug has been removed from the body for a long time and the drug is cleared and the person's physiology is sort of back to normal, the person still has a desire to take these drugs because they have what's called craving, and this craving is a long-term memory process, a notion that the drug will make them feel better if they take it. Now, how do these drugs work? How do the drugs that cause serious addiction work? We're talking in this case about heroin and other opioids. We are talking about methamphetamine and related compounds. We're talking about cocaine. They all work on the same systems in the brain. This system is called the limbic system. It is also the system that is responsible for pleasure and reward. When you have food, when you engage in sex, when you engage in physical activity. Some say that when women engage in shopping, the limbic system is stimulated and nerves in this part of the brain release a compound called dopamine, which in turn signals other cells. The way the brain works is, although it's a large electrical organ and signals within cells are propagated electrically, communication between cells is done by chemicals. And in the limbic system, the chemical that sends the signal from one cell to the next is called dopamine. So we're going to focus on what happens when these drugs of addiction are administered. In the case of methamphetamine, when a person takes methamphetamine, the release of dopamine from one cell to affect the next cell in the signaling pathway is actually increased. And as a result, the signal is heightened. So one of the things that people feel when they take methamphetamine is they feel an excitement, a stimulus, a feeling of well-being, at least in the short run, of extra energy, prolonged sexual activity in some cases, and an increased heart rate, and this feeling can persist for 8 to 10 hours with the administration of a single dose of methamphetamine. Opioids, on the other hand, also release amphetamine, but also release dopamine, but by a very different mechanism. And they do so by acting on cells whose normal job is to turn off the flow of dopamine, to reduce the release of dopamine, but in a cascade, heroin stops these cells from turning off the cascade so that more dopamine is released. In both of these cases, a prolonged exposure to these drugs changes the chemistry and sometimes even the wiring of the brain, so that once a person becomes dependent, they are no longer able to go back to the normal state, and the release of dopamine tends to be lowered unless these drugs are taken, consumed, on board, and active in the brain. Addiction results when addiction is actually a functional definition. If the person is incapable of stopping use despite negative consequences, whether that be arrest and being sent to jail because these drugs are illegal, whether it's alienating the members of his family or his community, whether it's losing his or her job, all of these things can result as a result of dependence upon a drug that they insist that they have to have, and that addiction will then, that use will then become an addiction because of the negative consequences. We can treat both the addiction and the dependence for heroin and other opioids by substitution therapy. This seems to work for heroin particularly well using a drug called methadone. And the reason it works is that methadone results in a slow and steady presence of a molecule in the brain that works in this cascade and keeps dopamine release relatively high, keeps the person feeling normal. It is, if you ask drug users why they take their drugs, if they're addicted, if they're dependent, they almost always say, I take this drug to feel normal. Now, they may feel some euphoria shortly after taking the drug. They may feel a high. They may experience some of the classic symptoms of drug intoxication with drugs like heroin, including drowsiness, because of effects of the heroin on other parts of the brain. But in the reward system of the brain, what they're feeling is a sort of return to a normal state, which is why a drug like methadone, which has a much longer half-life than heroin, which persists for a day or longer, which can make people return to work, restore their family structure, prevent them from engaging in crime, reduce the likelihood of a drug overdose. All of these benefits of methadone are the result of its action in mimicking, but more slowly and in a more coordinated, a more sustained way, in a more level way, the effects of heroin. Heroin, because of its short half-life, you feel the euphoria, it wears off, you need more heroin, you take more, you feel the euphoria again, it wears off, in a 3-4 hour cycle. Methadone, you take it once a day, you're probably fine. Not for everybody. Some people have different ways of metabolizing it, but for most people, methadone administered once a day can restore people to a normal, healthy life, even if they remain dependent upon the drug. But the dependence upon this drug in many ways is very similar to dependence upon insulin, or as I said earlier, antihypertensive drugs to control high blood pressure. What we're doing is we are restoring people to a sense of feeling normal, of feeling healthy. They can be very happily maintained this way for long periods of time. There is no reason to think that you need to remove people from taking this drug once they're stabilized on it and once it restores them to a situation in which they are no longer needing to take heroin to get high. They will do this. They will take this drug. They can take it for the rest of their lives if need be. They can try with medical help to stop taking it should they try to do it, but there's no reason to think that they have to stop taking methadone after any period of time. There's no reason to think that it's in any way harmful to continue on the drug. Studies from around the world, from studies that have been done in Asia, Australia, the United States, and Europe, have all shown that for 70 to 80% of heroin abusers, methadone is a very, very effective treatment for addiction. And by treating addiction, I mean very specifically that because it's medically prescribed and controlled by a physician who monitors the patient's health, the patient no longer has to engage in illegal activity, no longer has to steal money, no longer has to alienate his friends, his family, his community. He can return to work because the drug is very stable. The person doesn't go through periods of excessive euphoria or periods of excessive drowsiness. It's a drug that can be used in concert with a full-time job, and many people who had problems with addiction, who were stabilized on methadone, resume very, very normal, effective, productive lives. The complication comes for people with serious addiction who don't have a normal life to return to. For people like this, other assistance needs to be put in place. For many people, addiction became so powerful that they would spend much of the day trying to get the money they need to buy drugs, much of their time then trying to find the supply of the drugs they needed. And this was a full-time occupation. Not a very productive one, not a very socially useful one, but nevertheless full-time work. Once they're on methadone, which they can take in pill or liquid form in a few minutes, now the question is, what do they do for the rest of the day? If they don't have a set of skills, training, community to go back to, then they really feel very lost. One of the benefits of organizations like community-based drug user groups that have been set up in Vietnam is that they provide that community, that structure, that sense of purpose, that sense of being that often allows them to lead a very normal and productive life once again, to re-enter the community, to no longer be a drain on community resources, but instead be a benefit. For this reason, the combination of drug user groups, which provide social support, and methadone, is very effective in treating the addiction, turning the drug user from a problem in the community to a more productive member, a more socially useful member. This system is one that we've shown in our work to be extremely beneficial here in some work we've done in Hanoi, where we've compared drug users and former drug users who are members of such community-based drug user groups to people who are not members of the groups. And one of the biggest differences we found was that the people who were members of the drug user communities, these drug user groups, reported having a higher quality of life on both psychological scale and on the social scale. They also felt that they had better access to medical care, all of which is extremely important in restoring a normal and healthy life in a community, in a family. So what happens then when people are properly treated with methadone? The methadone is started at a low dose. The dose is escalated until two things happen. One is that the person feels normal, reports feeling normal based on self-report, but also you can test. If methadone is at the proper dose, the person no longer feels the need to take the illegal drug, heroin, because the methadone is high enough that the dose is high enough that they won't even necessarily feel the effect of the heroin, so there's no point in even taking it. So two things happen. One is you prevent the withdrawal symptoms, the immediate feeling of illness, and the second thing is that you prevent the heroin from actually having an effect, because methadone actually binds more strongly to the sites in the brain that control the release of dopamine indirectly than does heroin. So you have enough methadone there, you can add heroin without effect. However, many of these drugs, the methamphetamine drugs, the heroin drugs, affect other parts of the brain as well. The stimulant drugs, like methamphetamine and cocaine, increase heart rate, increase metabolism, increase sexual desire. by mimicking the release of norepinephrine, another neurotransmitter that works in other parts of the brain. Heroin, on the other hand, has the opposite effect on some of these parts of the brain. It actually slows the heart rate a little bit, but it has, more importantly, slows breathing. And heroin overdoses result when the breathing is so suppressed that breathing actually stops as a result of too much of this drug. Same thing can happen with methadone, which is why its administration and the level at which you have to take methadone to has to be monitored by a doctor. But heroin acts very acutely, and even methadone, which acts more slowly, an overdose can be reversed because it takes a while for this slowing of respiration to result in death. That there is a drug, an antagonist of the opioids called naloxone, which can be used to prevent overdose. In the United States now, for a dozen years, we've had campaigns, programs that have trained drug users to recognize drug overdoses that they witness in their fellow drug users. After all, drug using is a social activity and people do it together. So oftentimes overdoses are witnessed, but if people don't know how to respond effectively, they can't. And oftentimes, even though the overdose is witnessed by people, the person who's experiencing the overdose dies anyway. But by giving drug users naloxone, by prescribing it to them and teaching them how to recognize an overdose and administer the naloxone properly, which is not very complicated, we can prevent a lot of unnecessary overdose deaths. The pilot project for this in the United States was really work that was done in Chicago, where they were experiencing 600 overdose deaths a year until they started this naloxone program, after which the number of overdose deaths were cut in half, maybe even more than half. And clearly, there are problems associated with the idea of giving a drug to drug users to administer to other people, which is why a training program for the drug users is really important. But when we compared the knowledge and the practical knowledge of drug users who were trained to medical professionals who were also trained to administer naloxone in response to observed overdoses, both of them performed equally well in determining when a person was actually having an opioid overdose as opposed to some other kind of seizure, and in knowing how and when to administer naloxone and what to do in terms of providing other support for someone who was overdosing. Rescue breathing, staying with the person to make sure they recovered, making sure they didn't go out and take more of their opioids again, because what can happen is naloxone wears off, and if the person still has enough heroin in their blood or in their brain, they can again overdose a second time. We don't want that to happen. But with proper training, drug users are perfectly capable of standing in for emergency medical professionals and saving people's lives. And we've talked to people who have rescued other people by administration of naloxone, and they feel a particular sense of empowerment, a particular sense of competency, of success, of being able to save somebody's lives. And for many people, they say it's changed their lives, and it's for the good. And it's always nice when you're working with people who have problems with addiction to learn that they've done something that they feel good about. It's often the first step on the road to recovery.